Hi, everyone. Welcome back to the 2025-2026 Oncology Pharmacy Resident Clinical Pearl Series. Today, I'll be presenting on pediatric medulloblastoma. While we don't commonly treat many patients with pediatric malignancies, this is one that is good to be aware of because it is the most common childhood brain tumor. For the objectives of this clinical pearl presentation, I'll first describe the background of pediatric medulloblastoma regarding how common it is in the pediatric population, the prognosis of the disease, and risk factors associated with it. Then I will go into a deeper dive into the NCCN recommended treatment regimens according to the available literature. Before getting into the background of pediatric medulloblastoma, I'll first begin with a patient case to assess what you already know about pediatric medulloblastoma. Patient AB is a 2-year-old infant who was recently diagnosed with group 3 medulloblastoma after his mother reported that the infant was experiencing nausea vomiting for an entire week and brought her infant to the emergency department for further evaluation. This then led to the diagnosis of the malignancy due to detection from a brain MRI. Which of the following treatments do you think would be most appropriate for this patient? You can select your answer here, and then I'll go over this later on in the presentation after examining the available literature for NCCN recommended treatment options. The incidence of pediatric medulloblastoma among pediatric patients under 19 years of age is pretty low. However, it is the most common childhood brain tumor that accounts for 15 to 20% of childhood nervous system tumors, and is more common among younger children and males. The 5-year overall survival ranges from 65 to 70%, where there is about a 70% cure rate with combined modality therapy that involves surgery, radiation, and chemotherapy. There are different risk stratifications that I will define later in this presentation, in which patients that are of average risk have highest event-free survival of around 83%, while higher risk patients have an event-free survival that is the worst for patients under 3 years of age, while for those who are at least 3, the event-free is about 70%. The clinical presentation of pediatric medulloblastoma is nonspecific, in which a patient may experience nausea, vomiting, and headaches as a result of the increased intracranial pressure of the brain tumor. They may also experience ataxia, back pain, and loss of developmental milestones. It can be difficult for a patient or even the patient's parent to identify that these symptoms are a result of a malignancy, but if there is any concern that these nonspecific symptoms may not just be a result of a cold or other non-malignant conditions, it is really important to have the patient be evaluated as soon as possible so that if there is a presence of a brain malignancy, that it can be treated as soon as possible. With pediatric medulloblastoma, the risk factors for it are mainly driven by hereditary mutations, such as Lee-Frey-Mooney syndrome, which is associated with the TP53 mutations, Turcot syndrome, Lynch syndrome, CMMRD, Gorlin syndrome, and there are other germline mutations shown on the slide. With this type of brain tumor, it is located in the posterior fossa, in which it is a small round blue cell tumor of the cerebellum. There are 4 distinct molecular subgroups with varying prognosis and pathways of pathogenesis. These 4 subgroups are wingless, sonic hedgehog, group 3, and group 4. Group 3 and 4 were named because of the lack of clearly defined signaling pathways. And I'll go into more detail about each of these molecular subgroups in the upcoming slides. Shown on this slide is a diagram of this type of brain cancer, in which you can see that the medulloblastoma is located in the back of the head, where it is on the cerebellum. Brain and spine MRI are diagnostic imaging that are done to directly determine if there's a presence of the medulloblastoma in pediatric patients. A lumbar puncture is also done because the disease tends to metastasize via the cerebral spinal fluid. So this is done to directly analyze if any of the disease has been spreading to other sites in the body. Surgical biopsies are also done to determine the molecular genetic characterization to see what molecular subgroup the disease is a part of, and also directly determine the histopathology of the disease. Now, to start with the wingless subgroup of pediatric medulloblastoma, it arises from the lower rhombic lip and accounts for the least number of cases, but does have the best prognosis out of all the molecular subgroups, in which the event-free survival is greater than 90% with contemporary therapy. The median age of patients that have this subgroup also is older than the median age of patients that are typically diagnosed with pediatric medulloblastoma. That's between 5 and 8 years old, while for wingless it is 10 years old. CTNNB1 is also the most frequently mutated gene in the subgroup and found in a majority of wingless tumors that are analyzed. With the second subgroup, the sonic hedgehog medulloblastoma, it arises in a cerebellar hemisphere and accounts for about a quarter of medulloblastoma cases. The subcategories are classified based on age, as shown on the slide. The prognosis is also variable, in which infant sonic hedgehog has excellent prognosis when treated with adjuvant chemotherapy, in which the 5-year progression-free survival is around 82%, while for the overall survival is as high as 93%. The childhood sonic hedgehog with STP53 mutations, especially with MYCN and GIL2 implication, however, does have worse prognosis, in which the 5-year overall survival is around 40%. For the third subgroup of medulloblastoma, group 3, this accounts for about a quarter of medulloblastoma cases, in which the histology is mostly classic, but most tumors that do have the large cell anaplastic histology are group 3. The prognosis for this subgroup is the worst out of all the molecular subgroups, in which the 5-year overall survival rate is 20 to 30%, and there is a high tendency of metastases in 45% of cases. It does have some overlap with group 4 medulloblastoma, in which it's more common in male patients. The isochromosome 17q is confined to both the group 3 and 4 subgroups, and there are recurrent structural variants that include deletions, duplications, and inversions with the group 3 and 4 medulloblastoma subtypes. For the last subgroup, group 4 medulloblastoma, this accounts for 35% of cases, and the peak incidence is 5 to 15 years of age. For medulloblastomas of this subgroup, they mostly have a classic histology and intermediate prognosis, in which the overall survival can range from 75 to 90%. An association with MYCN amplification is not associated with inferior outcomes, and patients who do have metastatic disease do have a higher risk of relapse, except if there is the presence of either whole chromosome 11 loss or chromosome 17 gain, which identifies a favorable prognostic subgroup. So with this subgroup of medulloblastoma, it does have a more favorable prognosis compared to group 3, which has the worst out of all of the molecular subgroups. And like I said previously, there are some similarities, but main difference is the prognosis for this subgroup is a lot more favorable compared to group 3. Shown on this slide is a visual of the 4 different molecular subgroups and their associated mutations. While the molecular subgroups are good to know to have an idea of the prognosis of a patient's treatment, they do not influence the treatment recommended by NCCN. NCCN mainly recommends these treatment regimens based on the risk of the patient's disease, and this risk stratification outlines the criteria that must be met in order for the patient to be classified as either average risk or high risk. For average risk, all of these criteria need to be met, in which the patient must be at least 3 years of age at diagnosis, have a residual tumor of less than 1.5 square centimeters, no metastases, and no anaplastic pathology. While for high risk, if there's presence of any of these factors, then they're automatically classified high risk, where patients under the age of 3 tumor of at least 1.5 square centimeters, metastases, or anaplastic pathology would automatically classify the patient as higher risk disease. For the actual management of pediatric medulloblastoma, the actual treatment is generally a combined modality treatment in which the patient will undergo surgery, radiation, and chemotherapy. It also encouraged for the patient to enroll in a molecular classification-based clinical trial as well to see if there are potentially better treatment options out there specific for the molecular subgroups that I previously described. With radiation therapy, it is not recommended for patients under 3 years of age because of the association with long-term adverse neurocognitive effects, especially in infants and young children under 3 years of age. However, for most other pediatric patients, it is an important component of the combined modality therapy to ensure the best possible efficacy outcomes. With radiation therapy in older pediatric patients, it is recommended to start within 31 to 42 days of treatment. NCCN also does state that proton therapy can be considered for tissue sparing purposes, in which the use of proton therapy or intensity modulated radiation therapy can reduce exposure to the heart and liver during craniospinal irradiation. Now, to go back to the patient case that was introduced near the beginning of this presentation, the correct answer is D. The patient would only receive surgery plus chemotherapy as an appropriate treatment option. Radiation therapy is associated with long-term neurocognitive adverse effects in pediatric patients under the age of 3. So any radiation therapy would be omitted from their course of treatment. There's a clinical trial that I'll go over in the next few slides that covers this treatment option. And there is a caveat where irradiation was done after consolidation therapy if there was any residual disease or if a patient were to experience disease progression. But this is different than the craniospinal radiation therapy that is done with older pediatric patients. Shown on this slide are the principles of radiation therapy management that list the doses for low and average risk disease and high risk and very high risk disease. There are also other parameters for radiation management that are just listed on the slide just for reference. This is the study that covered the use of intensive chemotherapy and autologous bone marrow transplant in pediatric patients under 3 years of age, in which 62 children with a median age of 30 months with newly diagnosed malignant brain tumors after maximal surgical resection were enrolled from a time span of March 1991 to April 1995. They were treated with conventional induction chemotherapy that consists of vincristine, cisplatin, cyclophosphamide, and etoposide every 3 weeks for 5 cycles. Then they would undergo consolidation chemotherapy with carboplatin, tiotepa, and etoposide, and then undergo autologous bone marrow transplant. Irradiation was only used for consolidation if there was residual tumor remaining or for progressive recurrent disease. The results after all of these treatments were done found that 3-year overall survival was 40%, while 3-year event-free survival was 25%. As we'll see with older pediatric patients, the prognosis in patients under 3 years of age pale in comparison, and this can be explained from the omission of radiation therapy after surgery. After induction therapy, disease progression was noted in 17 children, and 4 children died from treatment complication. After consolidation therapy, disease progression was noted in 22 children within 15 months of autologous transplant, in which 3 children died of treatment-related complications, and 15 children were ultimately free of disease progression, in which there were no further treatment needed after 44 months. Shown on this slide are the recommended adjuvant chemotherapy regimens recommended by NCCN for treatment of pediatric medulloblastoma according to the risk stratification of the disease. And I'll go into the different clinical trials that cover some of these treatment regimens. Shown on this slide is a phase 3 study that examined the use of craniospinal radiation therapy and adjuvant chemotherapy in patients that had average risk medulloblastoma. They examined 421 patients aged 3 to 21 years with average risk disease, in which 42 patients were ultimately excluded from analysis. These patients were treated with craniospinal radiation therapy, posterior fossa radiation therapy, and then adjuvant chemotherapy, in which patients received either lomustine, cisplatin, and vincristine, or cyclophosphamide, cisplatin, and vincristine. The median follow-up over 5 years found that the event-free survival in these patients were 81%, survival of 86%, but patients who did have metastases had a 5-year event-free survival of 36%. In this phase 3 study, this examined the use of carboplatin isotretinoin in patients with higher risk medulloblastoma. This study was conducted by the Children's Oncology Group in the United States, Canada, Australia, and New Zealand from March 2007 to September 2018. Patients in this study, after receiving surgical resection, received craniospinal radiation therapy, and then weekly vincristine with or without daily carboplatin before radiation therapy. That's followed by 6 28-day cycles of maintenance chemotherapy with cisplatin, cyclophosphamide, and vincristine with or without isotretinoin. The results that the investigators found were that the 5-year event-free survival was around 63%, 5-year overall survival was 73.4%. Then the 5-year event-free survival with carboplatin was 66.4%, while without carboplatin was 59.2%. Shown on this slide are the treatment options that are recommended by NCCN for recurrent or progressive disease. In the following slides, I will go over the clinical trials that evaluate their efficacy. For the temozolomide, irinotecan, and bevacizumab treatment regimen, this was validated by the phase 2 trial that examined 105 patients with relapsed refractory medulloblastoma or central nervous system primitive neuroectodermal tumor. They randomized the patients 1-to-1 in a group that had the addition of bevacizumab to those that did not. What they ended up finding was that around 23.1% of patients in the bevacizumab group would complete the full 12 cycles of planned protocol therapy compared to 20.8% in the standard arm. The median overall survival was higher in the bevacizumab arm, where the median overall survival was 19 months with the addition of bevacizumab, while it was 13 months in the arm without bevacizumab. For event-free survival, it was also higher in the bevacizumab arm, where it was 9 months compared to 6 months. With the totem regimen, this was evaluated in the phase 2 trial that examined patients that had solid tumors and central nervous system tumors. The median age of patients in this clinical trial was 10 years, so a bit older than most pediatric patients that are first diagnosed with pediatric medulloblastoma. What they found with this clinical trial was that for patients that specifically had medulloblastoma, the objective response rate was 28%. And with the confirmed complete and partial responses was only observed in 4 medulloblastoma patients. For the last clinical study that I will discuss, this covers the carboplatin etoposide treatment regimen that is recommended by NCCN for recurrent medulloblastoma. This study examined 93 patients that had recurrent medulloblastoma, in which the median age was 10.1 years of age. The results of this study found that the objective response rate of patients who received carboplatin etoposide was 66.7%, while those who received temozolomide had a response around 35%. And then when they examined the longer-term progression-free survival and overall survival results, the IV chemotherapy group did have better results, but as you can see, the prognosis for recurrent disease is not very favorable. Now, for key takeaways to close this presentation, molecular subgroups do not influence the course of treatment for pediatric medulloblastoma, but they can be helpful for knowing the prognosis of care, and there's continued investigation to determine if they can be potential therapeutic targets. For patients under the age of 3, they do have the worst prognosis because radiation therapy is typically omitted from treatment due to association with worse neurocognitive outcomes. And this is very unfortunate because with the combined modality treatment, when patients do receive surgery, radiation therapy, and chemotherapy, they have much better outcomes. But when radiation therapy is omitted, we do see worse efficacy outcomes in these clinical trials that I covered in this presentation. Additional investigation also do need to be done to see if there can be better treatments, especially for patients that have higher risk medulloblastomas. Because a lot of these studies that were conducted did enroll patients that had a variety of central nervous system tumors or even solid tumors and did not compare them with other recommended treatment options, while the prognosis remains poor in the efficacy outcomes. These are the references that I used for my presentation for you to review at your own time. If you do have any questions or feedback, feel free to leave it in the YouTube comments or contact me at my Monument Health email at cchen1@monument.health. Thank you.